Hey guys, Nick here again to help you finish off this respiratory chapter with some high-yield pharmacology. Let's get to it. Histamine is an organic nitrogen compound that is classically involved in the allergic inflammatory response. The H1 blockers are reversible inhibitors of the H1 histamine receptor and are generally used in the treatment of allergies. Now there are two generations of histamine blockers, and they can be remembered based on their sedating properties. Remember that the newer second-generation histamine blockers are typically less sedating. More on this in a moment. The first-generation histamine blockers include diphenhydramine, dimenhydrinate, and chlorpheniramine. Now, when are they prescribed? Well, these drugs are used to treat allergies, allergic rhinitis, acute urticaria or hives, and motion sickness, and can be used for sleep. Now, outside of sedation, what other side effects do these drugs have? Urinary retention, dry mouth, blurry vision, and delirium. This is because of a cross-reactive antimuscarinic effect. They also carry some anti-alpha adrenergic effects like hypotension and dizziness. Now, would these side effects be similar or different to the side effects of atropine? Very similar. Atropine is a common antimuscarinic used to treat bradycardia. Toxicity of these antimuscarinics classically result in increased body temperature, urinary retention, flushing, and delirium. So these drugs should be used in caution with older folks. Second-generation antihistamines include loratadine, fexofenadine, desloratadine, and cetirizine. Like the first-generation antihistamines, they can be used to treat allergies and also chronic hives, but are more favorable for daytime symptoms because of the lack of sedation. Now, why do these drugs have less sedation than their first-generation counterparts? Because they have less penetration into the central nervous system. Flash quiz. Which H1 blocker is more likely to result in sedation? Chlorpheniramine or fexofenadine? Chlorpheniramine is a first-generation H1 blocker and thus will be more sedating. Always consider this difference when prescribing to the elderly. Alright, a quick word about expectorants, as this is just moderately high yield. The idea here is to clear the bronchiole of mucus. Guaifenesin is an expectorant that thins secretions. It actually has no suppression of the cough reflex. Now, how can you remember this drug? Well, the root of the word sounds a little bit like fenestrate, which, if you think about it, guaifenesin is poking holes in secretions to thin it out. N-acetylcysteine is an inhaled mucolytic that is used in cystic fibrosis, COPD, chronic bronchitis, and other chronic bronchopulmonary conditions with significant mucus production. Now, do you remember what other indications it has? Recall from your musculoskeletal pharmacology talk that this is the same agent used to treat acetaminophen overdose. Yes, cough and cold medicines are board testable. Dextromethorphan is a cough suppressant relating to opioids. Now, how does it work? It binds and blocks the N-methyl D-aspartate receptor, which is a calcium ion channel that's critical in memory and learning. Theoretically, in normal doses, it reduces coughing from minor throat and bronchial irritation. It has some abuse potential because it can cause dissociative hallucinations at high doses. Because it has mild opioid effects, what drug can we use as an antidote in case of a dextromethorphan overdose? Correct, naloxone. Flash quiz. What is the mechanism of action of guaifenesin? It thins secretions. Pseudoephedrine and phenylephrine are also commonly used in cold and allergy over-the-counter drugs as nasal decongestants. Now, do you know what causes the feeling of nasal congestion? Vasodilation of blood vessels of the nasal mucosa. Now, these drugs basically act as alpha-adrenergic vasoconstrictors to decrease nasal tissue swelling and congestion. They can be used in both pill form and as a nasal spray, but be careful that with prolonged use of topical decongestants, a peculiar side effect can occur. Do you remember the name of this side effect? It's called rhinitis medicamentosa, and it's a condition characterized by rebound nasal congestion that occurs after prolonged topical decongestant use. In addition to hypertension, tachycardia, palpitation, and stimulant side effects, what else do you have to worry about? Recreation drug abuse and pseudoephedrine, but not phenylephrine, can easily be reduced to methamphetamine in a meth lab. Pulmonary hypertension is a type of blood pressure disorder affecting the arteries coming from the right side of the heart into the lungs. Pulmonary capillaries are narrowed, making it harder for blood to flow through the lungs. The drugs used to treat this disorder are new and up and coming, but are still very board testable. The first class of medications used to treat this disorder is the endothelin receptor antagonists. Bosentan is the main drug used in this class and is specifically used to treat primary pulmonary hypertension. Bosentan works by competitively inhibiting the endothelin-1 receptor and thus decreases pulmonary vascular resistance.
Think about bosentan when you are asked about an endothelin-1 antagonist.
The next drug in this class is the phosphodiesterase 5 inhibitors. You might recall these drugs from your reproductive chapter readings because this drug class can also be used to treat erectile dysfunction. Do you remember the name of the primary drug used? Sildenafil, or what we all know as Viagra. Sildenafil prolongs the vasodilatory effect of nitric oxide in the blood vessels. The last class of drugs known to treat pulmonary hypertension is the prostacyclin analogs. PGI2 inhibits platelet aggregation and has a direct vasodilatory effect on the vasculature. Can you recall from the musculoskeletal pharm section which molecule directly opposes the action of PGI2? Correct, thromboxane A2. There are numerous classes of medications used to treat asthma, which could truly be a series of lectures in and of itself. However, understanding the basic underlying pathology involved in asthma exacerbations, as well as the mechanisms of various drugs to treat and prevent asthma, should make remembering the medications easier. Now, what is bronchoconstriction mediated by? Inflammation and parasympathetic tone. Therefore, some of the asthma medications target each of these pathways. Let's start with the parasympathetic pathways. Now, how is ATP converted to cyclic AMP? Adenylyl cyclase. And what mediates cyclic AMP conversion to AMP? Phosphodiesterase. This pathway is going to help you out a lot when you think of some of the asthma drugs. Beta-2 agonists relax bronchial smooth muscles. Ultimately, it increases cyclic AMP levels, lowers intracellular calcium levels, and causes smooth muscle relaxation and bronchodilation. Go back to the musculoskeletal section for a complete review of smooth muscle contraction and relaxation if you're feeling rusty. For acute attacks, albuterol is a good beta-2 agonist to start with. Long-acting beta agonists, or LABAs, like salmeterol and formoterol, have the same mechanism of action but last longer, so they are used with a steroid and a combination inhaler for asthma control. When could you use long-acting beta agonists alone? Well, they can be used by themselves in diseases with less inflammation, such as COPD. Theophylline is a methylxanthine that is used to treat both asthma and COPD. The mechanism of action is likely due to its inhibition of phosphodiesterase. Thus, you get decreased breakdown of cyclic AMP and then bronchodilation. Do you see how cyclic AMP is really the key to smooth muscle relaxation? Beta-2 agonists increase it by increasing production, and theophylline increases it by decreasing utilization. So what are the downsides of theophylline? Well, for one, it has a narrow therapeutic index. It has some nasty side effects including nausea, vomiting, arrhythmias, and seizures. It's metabolized in the liver by the cytochrome P450 enzyme, and therefore it interacts with a number of drugs like cimetidine and phenytoin. Theophylline and other methylxanthines like caffeine can block adenosine since they bind at the adenosine receptor as non-selective antagonists. Now, what's the clinical consequence of this? If you're using adenosine to break a tachyarrhythmia and your patient is on theophylline, it may not work unless you up the dose. So because of these headaches, we don't really use theophylline as much anymore, but they sure do make great board questions. Ipratropium competitively blocks muscarinic receptors and is used to treat COPD and asthma. Tiotropium is a new, longer-acting muscarinic receptor antagonist for COPD, and it mainly binds with the M3 muscarinic receptor. Okay, let's move on to another pathway of asthma, inflammation. Inhaled steroids like beclomethasone and fluticasone are first-line therapy for persistent asthma, especially when patients experience asthma symptoms more than a few times each week. They work by dampening the production of all cytokines, especially NF-kappa beta. Oral steroids like prednisone are used to treat acute exacerbations that are not reversed with short-acting beta agonists. What are the long-term side effects of chronic steroid use? If you don't know the answer, you can pause this and check out Cushing's syndrome in the endocrine lecture.
Now, a quick hint would be to remember that Cushingoid features, such as redistribution of body fat with truncal obesity, buffalo hump, and moon facies, are quite troubling to patients. The risk of these complications is both dose and duration dependent in regards to corticosteroid use.
Then there are anti-leukotrienes. Xyleutin inhibits the 5-lipoxygenase pathway. Is this upstream or downstream from the leukotrienes? As you'll recall from the musculoskeletal pharm section, xyleutin is upstream, preventing formation of leukotriene C4, then D4, and finally E4. And these are the products that are thought to be responsible for allergic inflammation, bronchoconstriction, and mucus production. Similarly, montelukast and zarfilukast, which is used less commonly, interfere with the action of leukotriene C4, D4, and E4 by blocking their binding to what receptor? That's right, cystenyl leukotriene receptor. Can you think of one special indication for the anti-leukotrienes? Treatment of aspirin-induced asthma. Finally, there's omalizumab. So what is it and how does it work? This is a monoclonal IgG antibody against IgE. It binds up serum IgE so that it can't bind to the Fc receptors on what cells? Correct, mast cells and basophils. Therefore, the IgE can't bind antigen and cross-link to cause mast cell and basophil degranulation.
It's used in patients with allergic asthma and increased IgE levels. These patients generally fail treatment with inhaled steroids and long-acting beta agonists.
Here's a summary slide to help you keep the asthma drugs straight. Pause here and make sure you recognize each of these drugs. Flash quiz. When can long-acting beta agonists be used alone? In COPD. Methacholine is an acetylcholine analog and a non-selective muscarinic receptor agonist that really has no practical therapeutic application. Instead, we use inhaled methacholine to diagnose bronchial hyperresponsiveness, which we see in asthma, and to a lesser extent in COPD. If the FEV1 drops by 20% or more with an inhaled methacholine concentration of 4 mg or less, then that is considered a positive test for airway hyperreactivity. Here's the methacholine challenge for a 63-year-old white female non-smoker with shortness of breath. On the x-axis, you can see the methacholine dosing concentration. You can see that her FEV1 clearly drops by greater than 20% from baseline when she reaches 1 mg, which would make this a positive test. So how are these results of the methacholine bronchial challenge test helpful? Well, this test is pretty sensitive. Remember the mnemonic SNOUT from the biostats? This means a sensitive test is used to rule out. So if it's negative, it's essentially ruling out asthma. But it's not very specific. The mnemonic there is SPIN, meaning that a specific test is used to rule in a disease. So here, if it's positive, then it may help you make the diagnosis of asthma with the right clinical context. But you have to worry about false positives because other conditions can give you a positive test like smoking, upper respiratory infections, allergic rhinitis, and GERD. Let's finish up with a board-style question. A 25-year-old woman with a history of asthma is brought to the emergency department by emergency medical services after ingesting a full bottle of theophylline in a suicide attempt. At presentation, she is having a tonic-clonic seizure, is hypotensive to 80/40, is tachycardic to 160, and is tachypnic to 30. The EMS personnel report that she has been seizing for at least 15 minutes. What is the mechanism of action of the most appropriate drug to counteract her intoxication? The answer is B, decreasing intracellular cyclic AMP. The drug theophylline is a phosphodiesterase inhibitor that leads to decreased hydrolysis of CAMP to adenosine monophosphate. An overdose of theophylline will therefore result in an elevated intracellular level of cyclic AMP. Beta blockers such as metoprolol may therefore be given to reduce the CAMP levels through inactivation of adenylyl cyclase. A cardioselective beta blocker must be used in cases of asthma to avoid inducing bronchial hyperreactivity. Alright guys, that finishes up the respiratory section. You guys are doing so well. Keep pushing through. You're going to crush this exam.